All right, cardiac pump. Really, we're going to get into some what I think is some pretty important depth. We're going to build on a lot of things that we've already talked about, and there I fully appreciate there's going to be some things that are almost a carbon copy of things I've commented about or lectured a little bit about in previous lectures, and that's by design. It's to help you paint the picture, if you will, of we're building this heartbeat. And so you can see where the overlap is and how it ties into what we've talked about earlier in the semester a little bit. It's also going to build pretty heavily on things that you probably hopefully remember a little bit from anatomy and physiology and next phys. I know Dr. Mush has at least talked about the concept of preload, afterload, and contractility and got into a little bit of depth, but in reality, it's just a little bit of superficial knowledge is what you've probably got at this point. We really need to get into some depth of understanding what is this concept of preload, afterload, and contractility, because they have major implications in the response to exercise and the response to disease. So you see, we're going to get into a variety of things here and such. Here's our clinical scenario, so I'll just outline it briefly and then we can come back and talk about the discussion points towards the end of lecture. So we've got a 60-year-old woman at a hospital complaining of shortness of breath, fatigue, swelling in the ankles and lower legs. She's had these symptoms for quite a while. She did not want medical treatment until they've really become severe at this point. She had rheumatic fever and had a murmur when she was younger. This was diagnosed as a mitral stenosis. We'll talk about later on, not today, but in more detail in the coming lectures. Revealed that she had some dyspnea, she has trouble breathing, she had edema, distended neck veins, and this is a really important clinical sign that relates back to cardiac function, so we'll get into that a little bit. She had a large, tender liver. This has important cardiac implications. And basically, I'm going to give you a preview of this. The distended vein in the neck and the distended liver, if the pump doesn't work very well, so you start having left and then right heart dysfunction, you get a backup of blood into the venous side. Venous pressure elevates, and that starts to get those things distended. These are early signs of what's going on. Her ECG showed the AFib, some right axis deviation. We haven't talked about that, but it's part of the case. Chest x-ray shows very large heart, some pulmonary edema. She has a very low cardiac output. And after a week of treatment for congestive heart failure, the symptoms have started to go away. She's sent home on medication therapy. So this is a very common scenario. And given the aging population, we expect to see this as a major scenario that you're going to probably see in a variety of situations, in your careers. So it's important, and in my mind, granted, I'm biased as a cardiovascular physiologist, there's important underlying mechanisms in physiology that we need to take into consideration here. So like always, I want to start basic and build from there. So let's start with a little bit of structural anatomy and understand some important terms, terms that hopefully you remember a little bit from previous classes, but ones that will be sprinkled amongst different topics as we build from here. So they're really fairly straightforward, but worth taking note about. So we've talked about myocardial tissue, and we're building our action potential in those things, but we can get a little bit more detail. And as you get into true pump function, these terms become important. So we have what's known as the endocardium. This is actually this inner layer of endothelial cells. So the continuous with that tunica intima, as you maybe recall, that we've defined a little bit already, of the large blood vessels. So it's just we've got a continuous endothelial cells of blood vessels, and we see those endothelial cells really within that inner chamber of our heart. And if we jump over to our figure a little bit, we see that we actually have in some places some trabeculae, some it's not this nice smooth surface inside the heart like it is the smooth surface of a blood vessel, but it's still lined with that endocardium. So this is just the flat endothelial cells. The outermost layer of our ventricular wall is the epicardium. Got more connective tissue, blood vessels. This epicardium, you can see down here, there's our epicardium, there's the endocardium. We can see here's these, that would be our large coronary blood vessel, and then we've got the blood vessels work their way from there. We've got a thick muscular layer. We've talked about this, and this is really where we're going to focus a lot of our attention is this endocardium. This is our muscle fibers. There's some connective tissue. It's important to recognize we need some structural components. And what we find is we take someone through cardiac rehab or different disease states that we have dysfunction or improved function of not only those muscle fibers, but we start to change the composition. So someone, say, following a myocardial infarction, where they start to replace those dead muscle fibers with more connective tissue, and that has implications. And then the subendocardium is a portion of that myocardium, but as the name suggests, it's the sub portion. This is the lower region, and it's important to bring up because this is a major area high risk for ischemia. So if we jump back over here to our figure a little bit, here's our epicardium, there's our endocardium. We've got this nice thick wall here. This is all really myocardium, and this little inner bit here, that's the subendocardium. So these are terms that if you continue down the path of cardiovascular physiology, you're going to see come up. Now, a lot of times, this is where we stop when we start talking anatomy, and this is really what we've known about cardiovascular anatomy for over 50 years. But more recently, with more advanced imaging and better understanding, we know that really this point one is pretty basic. And there's some really interesting information that's come out in the last 10 years about the orientation of myocardial fibers. And this is how we can get this great stroke volume in response to exercise with just a little bit of shortening of an individual cardiomyocyte. So unlike skeletal muscle, and you think about it, Dr. Barstow's muscle phys, you got this nice skeletal muscle, and we like to draw it out, and the sarcomeres are all this nice row, and we get this shortening. While we have that within the heart and the left ventricle, it actually wraps around in a very unique way. So I'm going to highlight a few things, reference my figure here, and then I'll give you some why it's important a little bit. So when we talk about this orientation, we start with, and we're going to relate this back to the terms up above. So the muscle fibers that are next to the endocardium, so they're really close to the inside of the chamber. So they're going to be in this region up in here. So kind of partitions that subendocardium. These are oriented up and down longitudinally. So if we look at point A on my figure here, we can just with this, we can see the sarcomeres are going from the apex to the base, up and down. So when these fibers contract, they're going to get us shortening along these arrows here. So we're going to see this shorten along what's referred to this longitudinal axis. This is longitudinal shortening. Now, if I look at the myocardial fibers, so in their orientation, how they wrap a little bit midway, say in the mid wall, they actually wrap in a different way. So they're, instead of being straight up and down like this in the endocardium, they're wrapped along here. So this is the apex. Up here would be the valves, and the atria would be up here. So this would be atria. So they wrap more, around the short axis, and these actually result in what's referred to as radial shortening. So if I take and I cut the ventricle and I look straight down into it, that's what I see with this radial shortening. So these, when they contract, squeeze it down like this. And then actually if we get out to the end epicardium, so on the very outer surface, they're somewhere in between. They're around a 60-degree relationship. Which means when these myocardial cells contract, they actually twist and they get some what's referred to as circumferential shortening. I bring this up because over the last couple of years, I've had quite a few students who take cardiovascular physiology, and after we go to the lab and you see the ultrasound, go on to ultrasound school, to ultrasonography, where basically you make a career out of using ultrasound to image the heart. 10, 15 years ago, you didn't need to know this. It was really useless information. The technology has now got where if you're an ultrasound sonographer or anybody related working with them, we now have the ability to actually measure the longitudinal, radial, and circumferential shortening. We can break it out by that. And that gives us massive information about cardiac performance. So that's why I want to make sure you at least understand these terms a little bit and what they're referencing to. What all this really means from a cardiac pump performance side is that for every single beat, you now have simultaneous longitudinal shortening, radial shortening, just the squeezing down, and the circumferential, which is more of the twist. All of these are happening at once. And if you look at the image, you can kind of hopefully visualize that a little bit. This means that a cardiomyocyte only has to shorten about 13% of its length. But this allows us to reduce the volume by over 60%. So it's the best way. A friend of mine who's a cardiologist down at UT Southwest Med, the way that they like to describe it is you've got a towel that's wet. What's the best way of wringing the water out of that towel? You're not just going to squeeze it like this. You're going to twist and squeeze, and you can get everything out. And that's what's happening to the heart. Is it's squeezing in all directions, and that gives you this massive ejection of blood with each beat. So I'm not sure I need to highlight anything other than just know that it's this movement in all directions, the longitudinal, radial, and circumferential, that allows us to eject 60, 70%. Like when we ultrasound athletes, we get ejection. We see 70% or more of the blood sometimes being ejected. Just amazing cardiac performance. But the actual cardiomyocytes that we're going to get ready and talk about here for the next couple pages or so really don't have to move very much at all. And this is partly how we'll get into this a little bit with stress and disease and exercise adaptation. How if you endurance train someone, you can get small changes in the length of a cardiomyocyte with endurance training and get huge changes in stroke volume. Okay, so let's get into the determinants of the force of contraction. This is where overlap happens between here and previous lectures. So it should make really easy exam questions. We know we have to have an action potential, and that's going to play a role in the release of calcium. But what goes beyond that a little bit? So the combined strength of contraction, how strong we get that radial, longitudinal, circumferential shortening is going to, the strength of that contraction when each cell determines the overall contraction of the ventricle. And we get major beat by beat variation in the strength of contraction via intrinsic and extrinsic mechanisms. There are things within the cell itself. That's what we're going to focus on initially here, as well as some external things that all can change how much strength of contraction actually happens. There's going to be some physical forces that we're going to get into, like preload that happen before the contraction, and those that happen after or during the contraction being the afterload. So let's quickly review excitation contraction coupling. And this is literally largely copied from a previous lecture. So we know at this point that in cardiac muscle, we've got to increase cytoplasmic calcium. That's what's going to initiate our contraction. So we got to regulate this calcium. And the strength of contraction depends both on the magnitude, so how much this calcium goes up, and the initial length of a sarcomere. This is where it starts to deviate a little bit from skeletal muscle. Skeletal muscle, I'm going to change the force of contraction by just the number of muscle fibers I'm going to recruit. Cardiac, you've seen a little bit with the action potential movement and the wave of depolarization. We're contracting every cardiomyocyte's involved in every beat. We're not going to change how many are contracting. We're just going to change each cell, how much force they generate. And we can do that by just changing how much calcium is released. And then the next bit is the initial length of the sarcomeres. So if we think about what drives this release of calcium, we know that action potential that we spent so much time building over here on the excitation side goes down that T-tubule. Here's our sarcoplasmic reticulum, and we get this calcium-induced release of calcium. So depolarization down the T-tubules, we get a little bit of calcium release from the L-type calcium channels that triggers the calcium being released from the sarcoplasmic reticulum. If you want to know the percentages, they're kind of here, about 80% from the SR and about 20% comes from these L-type calcium channels. And that gives us our contraction. So as we get this intracellular free calcium goes up, this drives the cross bridge formation. So this gives us the basic steps of calcium release. So it's, and then really 0.7 here just expands what I just highlighted there. When free calcium is high, we get cross bridge forms between those thick and thin filaments. And then we've got to get that calcium out. This is an important portion to cardiac physiology, is it's not just simply the release of calcium, the uptake of calcium is equally important. Because if we can't get it out of that cell, we can't relax the cell, and we can't have calcium for the next beat to happen. So we've got really some important steps, really two big ones that reduce that intracellular calcium. About 80% is actively taken up by the sarcoplasmic reticulum. And this is done by the calcium ATPase or SERCA pumps. They're located, as noted here, on the longitudinal, the long part of the sarcoplasmic reticulum. Give you a chance to write here. I know I've got a lot on here. So in between beats, we've got to pull that calcium out of the cytoplasm and we want to dump it back into the sarcoplasmic reticulum. It's got to happen very, very quick. As you think about during exercise, 180, 200 beats per minute, there's not a lot of time for that to happen. So these calcium ATPase SERCA pumps, and the ATP just tells us they require ATP to function. We don't need to worry about that. What really is important here and going to be very important in a couple slides is, well, what regulates how quick that calcium comes back up? It's not only how many channels there are. So again, they're all going to be out here in kind of this longitudinal part. So here's our pump. So this is our ATPase, our SERCA. It's going to take up about 80% of that calcium. It's regulated by an important protein, by this phospholambin. Now, I'm not going to highlight the second bit here. You don't need to know about it being phosphorylated and those things. That'll it's a little bit more depth than I think you need to know from an exam standpoint. But if you look at my figure over here to the right a little bit, so here's our circuit pump and our calcium. Here's our SR lumen, and we want, calcium. When this phospholamban is here, when it's attached to our circuit pump, the magnitude of how quickly we can get calcium in is lower than if we take away that inhibitor, if you will. And what we're going to find, you're going to have to just trust me a little bit, is that this phospholamban, this is how we can improve the rate of relaxation during things like exercise, and how we'll get into some external factors. This is how they work. And about 20% of the calcium, we use the sodium calcium exchangers. This is in the sarcolemma, and calcium ATPase pumps. Basically, we're pumping it out of the cell completely. If we can really see that a little bit in my figure here, where we have both the excitation side of things, the release of calcium from, here's our L type, this is the L type. Here's our iodine receptors, and we get the release of calcium here. That drives our cross bridges. And then we've got then the circuit pump bringing it back in, and our exchangers getting things back to normal. Where this really, again, important point, where we see deviation from and differences in cardiac versus skeletal muscle, is that we can modulate the amount of calcium being released, and therefore regulate the amount of cross bridge and the force of contraction. So we get different intensities of actin-myosin interactions, different intensity of contraction or strength of contraction from a single action potential. So that action potential spreads across based off how much calcium gets released into the intracellular space, dictates how much force of contraction we get. This is all dependent on how much calcium reaches those myofilaments and activates the cross bridges. This is what allows us to change that contractility that we're going to really focus on. Contractility is critical because it's one of the most commonly used markers of true cardiac performance. We can look at this a little bit by just looking at the relationship between calcium and the force that's generated. That this is free calcium. So this would just be calcium. I'm just going to put a plus here. This would be same calcium in here. Now, if we increase this, we're going to move along this line here. That's this. As we increase the amount of calcium, we increase the amount of force that can be produced. Just a simple relationship, but it's a very, very important one. So if we can dump more calcium with each beat, we're going to get more force produced. And what we're going to see is this line here, this line here. There are certain things we can do to shift that so that we can get, for any amount of calcium, we might even get more force produced. So it's a fluid line, if you will, a little bit. So kind of putting that in your back pocket, let's start getting into the concept of preload and afterload and how that dictates the force contraction of this concept of contractility a little bit. So we've got this concept of amount of calcium released drives the excitation contraction. We've got some extrinsic factors, that being the initial length of the sarcomeres, that initial stretch is going to change that relationship a little bit. This is where preload comes in. So I'm going to give you a second here to write these, and then I'm going to really build on it a little bit, because I'm going to have to go from my text to my figure. So let's start with a couple definitions and then visualize them with our figures. First is this concept of resting tension. So this is the force required to stretch resting muscle. In this case, cardiac muscle. If I can take it, could cut it out of the heart, it's not doing anything, it's completely rest, and I can stretch it. It's going to take some force to stretch that. The same way if I take a rubber band, it's not contracting itself, it's not alive. I stretch it and it takes some force to stretch that. This is preload. This preload force is what we're putting on it before it's activated. That's where the term pre. So it's the tension on to the muscle, and we're passively stretching it. And this gives us what's referred to as the passive length tension relationship. We just measure the force produced as we stretch it. All right, don't worry about point 12. Let's go down to my figure and talk about this resting tension a little bit. There's a lot going on here, but I'm going to start with this up here. This is at rest. We've got a resting length. There's multiple lengths here. So here's the shortest, next, and next. So I stretch this muscle a little bit. Every time I stretch it a little bit further, a little bit more force is required. And that's what gives me this passive, that as I stretch and increase its length, at some point, I start generating a little bit more force, and that gives me this passive curve here. The same way as I take a rubber band, I stretch it a little bit, it's a little bit of force. Once I really stretch it, now there's a lot of force trying to pull it back in. So the same thing happens with our cardiac tissue. Now, if I stretch it and I hit it with that action potential we've built over the last several weeks, so I stimulate it to contract while I stretched it to a certain length, and I hold it there, and I don't let it move, but I hold it stretched, and I hit it with an action potential, and it releases the calcium, and it gets those cross bridges, and it generates more force. This is referred to as active tension. So it's now isometrically contracting. I'm not letting it shorten its length. I'm holding it still, holding that length constant, but because it's been hit with an action potential, it's producing more force. And what we see is as we increase the preload, and that increased preload stretches the muscle further, causing both an initial increase in the length and up to a point, greater force development. So if we jump down here are my 4 different lengths. If I stretch it and I then hit it with an action potential and I see how much isometric force it can generate, we can see 1, 2, 3, and 4. We can see there's different amounts of tension produced. And if we were to kind of transpose this over here to my figure a little bit, just put 1 right here. So I stretched it here and it generates that little bit of force. I stretch it to say 0.2 and it's going straight. My lines, I'm driving my arrow straight up because it's isometric. So the length of my muscle fiber doesn't change. So I'm not moving along my x-axis here. It's just going straight up. If I put 3 here, so I stretched it a little bit further. I've really stretched it here, and I've still generating more tension. But if I stretch it too far, like 0.4, might come back down like this. So this is the active tension. So right now I'm just taking a section of muscle out of the heart. I'm holding it in my hands here. And the total tension, that's kind of where my point B, which is my top line here, it's just how much force, it's the sum of both the active and passive tension. Passive being the tension produced, the force produced by me stretching it, and the active is the cross bridge formation when I hit it with an action potential. This really sets up the total operating curve or area in which the heart can work in. It can't go beyond these lines. This is the maximum amount of force it can produce up here. It can't get any more than that. This is where it's at in this particular state. It has to work in this envelope. Well, we know that the heart doesn't just contract isometrically. It actually has to move. It has to change the volume to eject blood. So we have to take it a step further. Oh, apologies. I need to highlight a point here. So why is it that as I increase this length up to a point, why is it as I stretch it, I get more force? And you've probably talked a little bit about this in some previous classes. And the biggest one, the one that hopefully you remember the most, and this is the classical way of thinking of it, is it's just amount of overlap. That if I stretch it a little bit, I get ideal overlap between those thick and thin, or those actin and myosin fibers. There's a sweet spot. Usually we say that peak tension developed when those sarcomeres are in that 2.2 to 2.3. If I jump to my figure over here, there's actually cardiac and skeletal muscle. We don't need to worry about the skeletal muscle side. But here's our sarcomere length. Here's the tension. And here's our curve. And this curve, really just this curve. Just a different way of looking at it. That as I stretch it, get a different length, I get more tension or more force developed. So the overlap theory, that's the predominant one, the one we've taught for 50 years. We now know that it's a little bit more complicated than that. Not only is it the overlap, but as we change that length a little bit, we change the sensitivity of actin and myosin to calcium, such that at longer lengths, as we stretch it out, we can actually activate more cross bridges. And we also know that as we stretch and increase the length, we actually get a little bit more calcium being released. It's because we now know that there's these stretch sensitive ion channels in the cell membrane. So that as you stretch the heart a little bit, we'll talk about how this actually happens in the intact heart in a little bit. As you stretch that heart, it's actually there's these stretch sensitive ion channels that allow more calcium to be released. As we've already seen, more calcium, more force of contraction. So this is preload. We stretch it, we can, as we increase the length and increase the stretch or increase the preload, we get more force up to a point. Well, the heart doesn't work in isolation. It has to actually work for a living. So that's where the concept of afterload has to come into play. So we're going to still stick with our strip of cardiac muscle, still kind of at the cellular level. And trust me, this will all be really important when we start talking about the intact heart. So if we take a strip of cardiac muscle, hanging it here, and I put some extra force on it, an additional load, I'm going to make it work for a living. This is the scenario of afterload. Is I'm putting an extra work on it, and it's now an afterload type contraction. So it has to generate some force before it can shorten. In the intact heart, this afterload is the stress applied to the ventricle as it's ejecting blood. How hard is it to eject blood into the circulation? This is sometimes a little bit of a challenging concept to fully wrap our heads around. So I'm going to really break this down a little bit with some text and a little bit with my figures a little bit. I'm going to actually start with my figures. I'm a visual person, so that's what I want to do. So let's start over here with point 1. So I've got my cardiac tissue and I've stretched it. Just a little bit of tension, a little bit of stretch, and that puts me right here. So here's my muscle tension is 1 gram. So I've stretched it. The tension is 1 gram. I've stretched it to here. And I'm not going to add any work to it. I'm going to make it easy. I hit it with an action potential and it shortens. And it goes to point 2 and it keeps shortening to point 3. So here's point 2 and point 3. And here's our peak. This is this line here. So I'm going to star this. This is the same as that star. It's the same as that star. It's the same line. It can't go beyond that. So if I just take a heart and I don't have to make it work at all, I hit that muscle, it's going to just quickly shorten. But that's not what happens in practice. If I put a little load on it, like it would in the intact body, I'm going to come up here. I'm going to go, let's use blue here. Here's point 1 again. I've still stretched it to right here. I've added 2 extra grams of work to it. That it's here. Now I hit it with an action potential. So I'm going to hit it with my action potential. And it starts to contract. And it starts to generate some force. So the tension starts to rise. But it has to, like you picking a weight up off the ground in the gym, you can't just instantly lift it. You have to generate force until you've generated enough force to lift it off the ground. And the heart has to do the same thing. So it gets it to this point here, or point 4, where it's now generated enough tension to our 3 grams that now it can start lifting. And that's where it then works its way over here. So this really highlights that we're working within this envelope a little bit. So if I come back here, if the afterload is such that the muscle can generate enough force to lift the load, it'll initially contract isometrically. And once it's got generated enough force to lift that afterload, it will start to shorten. This is going to be important when we look at a cardiac cycle, because there's phases that are the isovolumic contraction period or phase. That's what's happening in here. So initially, tension developed isometrically. That's my point A. Point B, muscle generates enough tension to equal that load. Now the tension output is fixed and it shortens isotonically. And then once it's generated enough produced to change the length, that's what we get, the shortening. This afterload not only determines, how much force it can lift, it determines the velocity. So the velocity is fastest or maximal when there's no afterload. And as I start adding more load to it, you might expect, the velocity goes down. So we can look at this in a variety of different ways. Here's our force and our length. So if I stretch it a little bit and then I hit it with, this is my action potential here, my little lightning bolt, generates some new force. So force goes up. The length, we get some shortening because the shortening of that's our contraction. That velocity is just how quickly does it drop. And if we look at the force velocity, if I have force at 0, so I'm making it's taking away all work that it has to do. The velocity is really, really high up here around 10. You don't need no 10. That just make sure you can see where I'm at. And then as I increase the force and increase the afterload, the velocity of shortening decreases. And what we'll see here coming up in the next point, we can change this relationship between force and velocity with things like norepinephrine. So decreases to zero when we start. And if we add too much force, it eventually can't shorten at all. That's what we get down here at the far end. So much force that the velocity is zero. So contractility, we've got preload, we've got afterload, excuse me, and now we've got contractility. How do we change the force of contraction with external factors? So any intervention increases the peak isometric tension that cardiac muscle can develop at any given length increases the contractility. And we use the term positive inotropic effect on the heart. So a positive inotropic effect is going to increase the tension that it can develop at any given length. One of the most common ways in which we can do this is with norepinephrine. Now, we're not going to get into the autonomic side of things in too much detail, but we've already mentioned in previous lectures that we release norepinephrine via sympathetic nerve fibers. That's going to increase heart rate. Well, you probably, hopefully remember from 335 that with increase, as you progressively increase exercise intensity, you get greater sympathetic nerve activation. And Dr. Mush probably said that you get an increase in contractility with sympathetic nerve firing. And this is how it does that. So we get this norepinephrine. And what that does is it increases the peak isometric tension curve. So if we jump to my figure over here, here's our length, here's our tension, here's our resting tension. Notice resting tension, it doesn't care whether norepinephrine's around or not. So this is me just stretching it. But if I hit it, here's where we were at before without norepinephrine. So I'm going to star this. That star is the same as that star, is the same as that star, and the same as that star. Norepinephrine allows us to just generate more force. For any given stretch, any given muscle length, norepinephrine means we can generate more force. So we now move up this line here. And that's whether it's an isometric or under afterloaded conditions. So remember with afterloaded, like picking up a weight off of the ground, we have to generate a little bit of isometric force first until we generate enough force that it actually comes off the ground. Same thing here. Here's with norepinephrine. So improved force. So we get more forceful contraction for any given muscle length. The cellular mechanism is through interaction of the beta-1 adrenergic receptor. Remember, we mentioned the beta receptors in the SA node. That's what allows us to increase the heart rate in the generation of the action potential or SA node. Well, now those same receptors are scattered throughout the myocardium. And they activate a G protein coupled pathway. I'm not going to highlight that. It's there if you want. So it's a G protein, cyclic AMP, protein kinase A, phosphorylates calcium. The main thing is norepi binds to beta-1 receptors. We get more inward calcium, particularly in that plateau of our action potential. More calcium means we've got more calcium for each given beat, and we get a better contraction, more forceful contraction, because we've just released a higher amount of calcium. Now, if we're releasing more calcium, means we got to get it back out between beats. And that's where we have the concept of a positive lustropic effect. So norepinephrine increases the rate of muscle relaxation, going back to that phospholamban I mentioned. Remember, the phospholamban regulates that circuit pump. So if you've got norepi, binds to this beta receptor, here's our circa. Here's the phospholamban, that PLB. So we bind some norepinephrine that takes that phospholamban away, makes it easier for calcium to get uptaken. So we can pull the calcium out between beats, and we're putting more in with each contraction. This is a positive lustropic effect. Now there's been debate. This is so that's the sympathetic side. It's going to improve contraction and relaxation. What about parasympathetic? So there's a little bit of evidence that increased parasympathetic activity can have a slight negative inotropic effect, meaning less contractility. This appears to be almost entirely at the level of the atria, and it may be due to just changing the action potential. I'm not going to highlight the point box A. So there's maybe some evidence, but it's minor. And it appears to have a minor role in contractility. So here's a clinical box. For the sake of time, I'm not going to dive into it because I want to get a couple more points in and then get us out of here. So it's just a nice clinical box that relates back to some of the concepts if you're interested. So we've got this concept of preload, afterload, and contractility, and we've really focused on it from the level of the individual cardiomyocytes. And that's important. You've got to understand what's happening there, so that as we start looking at the entire heart and the entire cardiac cycle, we can understand why those things are happening. Because it's at that cellular level that we see changes in response to exercise training, disease, and different medications. So I'll give you a second here to write these terms, and then I'll talk about them just briefly. So the cardiac cycle, and I'm hoping, and I apologize, I'm going to highlight all of this. They're all basically definitions, and hopefully they're definitions you know at this point. You've had them in previous classes. When I refer to the cardiac cycle, I'm talking about everything. The electrical changes we've spent several weeks talking about, and now the pressure and mechanical, and it's important. We need to consider both pressure and mechanical events that happen within the heart, the greater vessels, to and away with each individual beat. So it's each beat. When we're talking cardiac cycle, we're talking about a single heartbeat. We've got a period of diastole, which is relaxation, and systole, which is contraction. And if we say ventricular systole, we're talking about just the ventricular, the tissue contracting, and atrial. And it's important that we distinguish those at times. Cardiac output, we know, is heart rate and stroke volume. And that stroke volume is, how that volume of blood ejected with each beat, with each phase of the cardiac cycle. And it is the difference between in diastolic and in systolic volume that give us that stroke volume. So these are some nice definitions, but what do they really mean, and how do we understand them in a way that we can put them to our advantage, whether we're training an athlete, training a patient, anything in between. So I'm going to talk about this figure a little bit, but I'm actually going to pick it back up at point 23 on Thursday when we start lecture. But I just at least want to close the loop a little bit. This is our cardiac cycle here. We can really, because it's each beat's happening over and over again, at least that's what we're hoping, we can really start the cardiac cycle at any point, just a matter of where you want to say go, because it is a cycle, it's circular back on itself. But we've got periods of passive ventricular filling. And again, think about it, what we've talked about, the sequence of events a little bit when we talked about the wave of depolarization. So we've got a period of ventricular filling, period of atrial contraction. We've had to have our what's referred to as an isovolumic contraction, and that's what I've got here in point 23, where all the valves are closed. There's no change we're generating a lot of force, but there's no actual shortening of the myocytes. We're just generating some pressure. This is our isometric contraction. We then generate enough pressure that we can open the valves and we get ventricular ejection. We then have a period of isovolumic relaxation, and then we start the cycle back again with passive filling. There's important functional things happening at each of these relate back to the things we've talked about so far today. On Thursday, I'm going to pick up at point 23, and I'm going to relate these, this cartoon here. It's a nice way to conceptually understand what's happening in the cardiac cycle. But it really tells you nothing about an individual athlete or individual patient and how things change. What we're going to build next time is this diagram here on the far right that has everything. Pressure. So we've got pressures, aortic blood flow, ventricular volumes, heart sounds, our ECG is down here, and our various phases here. This is the Wigger diagram. This was one of the most fundamental things in cardiac physiology is understanding this Wigger's diagram. It's kind of a central point, and that's why it's really central in my lecture, because you can build it backwards to basic cellular physiology, and you can build it forward to very, intact cardiac performance, which are both very important. With that, that's all I've got for today. Again, if you've got questions beyond what I know I'm going to fix for the exam, just come on up. And otherwise, I will see you on Thursday.